delighted to introduce to you Megan Niskern, and she will be presenting us with Eating Disorders, Gastric Bypass, and Binge Eating Disorders, a Dietitian's Perspective. And my name is Libby Neal, and I'm the Executive Clinical Director of Training and Education for the ROSEWOOD Institute. And there will be a time for question and answer at the end of this presentation, and the final slide will include my contact information. If you have any questions or would like a copy of the slides, I'm more than happy to send them out to you. And on that note, I am going to pass this over to Megan.
Thanks, Libby. So I want to say first that I'm very excited about this topic. I feel as though this field of the eating disorders is really expanding. So a little overview of what we're going to be talking about today. The first is this a medical or a psychiatric condition that we're treating? How gastric bypass or any bariatric procedures, binge eating and eating disorders are intertwined. The dietitian's role in treating these illnesses and these different conditions, and an introduction to gastric bypass complications and concerns, and again, how those play into the eating disorder. And then we'll have some time for a few clinical case examples from some of the different levels of care to discuss at the end. So going into a little bit of detail about bariatric procedures, generally there is a standard for what it is that a person needs to have in order to qualify for a bariatric procedure. And the first is they have to have a BMI above 40. There are some different exceptions, however. If someone were to have a BMI above 35 and obviously below 40, and then also has some medical conditions that are secondary to their overweight status, such as high blood pressure, type 2 diabetes, severe sleep apnea, they could then also be a candidate to have one of these procedures. It's important to also note that different medical facilities, depending on where you're having these bariatric procedures, and different insurance companies, some of which do cover partial or full bariatric procedures, have their own standards as well. Some of those can include a medically supervised, doctor-supervised 6-month weight loss program in order to get the person on a path that's going to be helpful for them after the procedure. And then there's also a lot of different screening processes that are gone through, meeting with dietitians, meeting with physicians, even meeting with therapists or psychiatrists to establish where they are in their relationship with food. And we'll talk a little bit more about that as we move along. Other than weight and having obviously a high BMI and being overweight or being obese or severely obese, there are different reasons to have a bariatric procedure, some including severe gastroesophageal reflux disease or GERD, having heart disease, and then high blood pressure, which we had talked about previously, type 2 diabetes related to being overweight, severe sleep apnea in relation to being overweight, and then the risk or the previous incident of stroke. So all of these reasons on top of the bariatric weight-related reasons would be reasons for someone to have one of the procedures. So I thought it'd be good to go through just a little basic overlay of some of the most common procedures. There are 4 of them. I'm going to talk a little bit in detail about 3 of them, the most common 3 that are seen right now. And the first is the laparoscopic adjustable gastric band. This is commonly known as the lap band procedure. What happens is laparoscopically they go in and a band is placed around a very small section of the upper stomach. So it's essentially creating a very small stomach pouch. And this reduces the amount of food that can be eaten in one sitting. So that pouch gets full, creates the feeling of fullness, and then the food slowly filters through the stomach and through the rest of the intestinal tract. So with this particular procedure, there's actually no manipulation of any of the intestinal tract. Nothing has changed. But what happens is after the procedure, the doctor goes back and checks on, recovery, and then a saline solution can be inserted into the lap band to either tighten that band by filling it with saline and making it more constricted, or removing saline from the lap band, creating a greater opening and less restriction. And so it's a process between the patient and the doctor to determine how much weight loss is occurring, and then food tolerance or any kind of negative side effects. I thought it was really interesting that this is the most common bariatric procedure done outside of the United States. The second is a laparoscopic gastric bypass. This is more commonly known as a ROUNY. procedure. And here, a small upper portion of the stomach is actually stapled off and connected to a lower part of the small intestine. The rest of the stomach and then the upper small intestinal tract are then connected back to each other and then back to the lower small intestine. So if you're to see a visual of this, this actually creates a Y. So it's coming down from two different sections of the stomach and all reconnecting at a point in the small intestine. So what this does is it doesn't remove anything from the body. It just recirculates things through the system. So all digestive juices and all gastric juices reach the food. However, it's happening in different places in the body, and so the result can be that there's much less absorption of nutrients and of calories. And this is the most commonly performed procedure in the United States currently. Thirdly, we have the laparoscopic gastric sleeve. With this one, the stomach is actually reduced and the excess stomach tissue is removed from the body. So what happens is the stomach is reduced to about 1/10 of its usual size, and it kind of looks like a banana, and is actually about the size of a banana. But there's no rerouting of the intestinal tract. So essentially the stomach is just reduced and everything continues to happen throughout the intestinal tract as normal. A slide that I did not include on here is the fourth of the bariatric procedures, and that is the laparoscopic duodenal switch. It's a very, very complicated procedure that is not commonly done. It is considered to be a second stage procedure. So for instance, if someone had possibly done a gastric sleeve or if somebody had had the Roux-en-Y gastric bypass and it wasn't creating the results that were desired, sometimes they move on to doing the duodenal switch procedure, which can be looked up online and it's pretty in-depth. So in looking at these different bariatric procedures over time, we're really starting to see how they're having impact on eating disorders. Disordered eating or eating disorder behaviors are oftentimes present even before having these surgeries. And as I had talked about earlier, there are different screening processes that every facility has in place in order to hopefully avoid allowing someone with these disordered eating patterns to have a procedure and therefore have complications secondary after these procedures. However, those things aren't always caught. So it's important to recognize that they can manipulate this process. And we do oftentimes see people that come in and talk about how they had this relationship with food and their binge eating was essentially so out of control that they had this procedure hoping that it would fix things. And in fact, after the procedure, they found that they had really lost their coping mechanism. Another instance of how the impact of these procedures on eating disorders is that the eating disorder behaviors can easily mimic side effects of these procedures. For example, the gastric bypass Roux-en-Y procedure specifically can really result in having an involuntary vomiting reflex. If the person eats just slightly more than their stomach is capable of containing in that moment, then their body will literally get rid of that food. And it's difficult to console with someone and say, are you purposely allowing this to happen, or is this something that you have absolutely no control over? And we're going to talk a little bit about how to work with that further on in the procedure. Another thing that can be a mimic of an eating disorder behavior is the restricting factor. Oftentimes, and with all of these procedures, very specific dietary guidelines are given to these patients even before they have the procedure so that they understand what they're getting themselves into. And when it comes to these dietary guidelines, it involves a very restrictive amount of carbohydrates, a very high protein diet in order to make sure they're getting a lot of those essential amino acids. And oftentimes they're told that they really shouldn't have any desserts at all. These are a few of the guidelines. And imagine if you were a person who was a binge eater previously and maybe had indulged constantly on carbohydrate-based foods and different types of desserts after this procedure, you're essentially being told not to have them at all. And the reason for that is you're already at a restrictive calorie level. You're not absorbing these nutrients, and so it's important that everything you put into your body is a high nutrient food and you're getting everything that you need in order to maintain a healthy balance that's not just weight related, but also in how the body is functioning. The bariatric procedures, like I had mentioned earlier, can take away a coping mechanism. For instance, most of these people that have the binge eating before these procedures now don't have any coping mechanism that they can relate to or that they can go to easily. So it oftentimes can lead to a switching of behaviors. At our inpatient facility, we've actually seen 2 patients who came in as previous binge eaters, had one of the bariatric procedures. Actually, one was a lap band and one was the gastric bypass. And now they were not only restricting severely in order to try to expedite any kind of weight loss or get to an extreme place in their weight loss, but they were also taking to alcohol. So it would take very little alcohol for them to, in fact, get intoxicated. And that was their coping mechanism if they were having a difficult time that day. So it really doesn't fix the issue at hand, which is that this is a coping mechanism for other underlying issues. It just changes the way that they're going to react to those instances that they can't handle. Over time, the results of these procedures can be manipulated. Many times, actually, at our inpatient facility, we see those people who have had either the lap band or the gastric bypass more commonly that have lost a bunch of weight and then gained all of that weight back. These procedures are not foolproof. Like I said, there's dietary guidelines, exercise guidelines, medical follow-up, all of these things that they need to make sure that they're staying on top of after their procedure. And if they don't, then they're not going to be able to maintain the weight loss. So you can re-stretch the stomach, even if you've had a gastric bypass procedure and the stomach has been stapled off. That tissue is definitely pliable, so you can continue to overeat and overeat and overeat. And again, it's a process that takes many years for most people, and stretch that stomach back out. When it comes to the lap band procedure, we oftentimes see that they're not eating the 6 small meals a day that are recommended, and in fact, they're grazing on food all throughout the day. So the second they feel as though their stomach is no longer full, they're not waiting until the next meal. In fact, they're just continuing to eat every time that their stomach is empty. And that's almost kind of their secondary binge eating behavior that's going on. So obviously it can lead to a lot of different medical conditions that can present themselves post-bariatric surgeries. These procedures can change the physical body. They can force the weight loss to happen, but they're not necessarily going to change the eating disordered thinking, or like I had talked about, the different coping mechanisms that these people have in order to deal with the issues that are underlying. Some of the observations, these are some generalizations that I've had in working with a growing population of binge eaters and those that are post-bariatric procedures with eating disorder tendencies, is that oftentimes we see that it's women over the age of 40. We most recently had at our inpatient facility at one time 4 women over the age of 40, 2 of which had been post-bariatric and 2 were just binge eating. We also had 2 at our partial hospitalization level of care. They were actually in their mid-20s. Neither of them had had a bariatric procedure. But a lot of times we see that they're women over the age of 40. In general, with binge eating and with bariatric, post-bariatric, we find that they want to put in minimal effort to their recovery, to the food, to the exercise, to the things that they need to do in order to create the change that they're hoping to see. And they have very high expectations when they make even the smallest changes. So for instance, they follow their meal plan appropriately for 2 days and they come in and all they want to know is how much weight they've lost, or all they want to know is what's changed in their body. And there's essentially a really long period of buying into the treatment and the recovery process. We really see a lot of times a struggle with being honest about food behaviors. There's very strong feelings of shame in having to admit to consistently binging or overeating or having grazing behaviors. There really is almost, with every bariatric or binge eating person that I have worked with, there's almost an extreme state of denial that's a little bit more extreme than I've seen with the anorexics and the bulimics who do manipulate as well. But they really have no recognition of what they're eating on any given day. One person that I have worked with for many years now actually had a term for the binges as being blind binges. other words, it was almost as if she didn't even know that they were happening, and they would happen multiple times during the day, and it took a very long time for us even to be able to get out of her an idea of what a blind binge would look like. So a lot of struggles in getting to a good place with their recovery because they're just not being honest. And another thing that can happen, obviously, with the weight is having an excessive amount of joint pain, a limited ability to move around with daily functions. So you have to be really careful what you're asking these patients to do, how hard you push them. You want to make sure that they're medically stable for a lot of the things that you're asking. But at the same time, you do want to push them to increase their muscle mass and to reduce their fat mass and to start getting their body back into a healthier state. We have some discussion topics here that Libby and I thought we would maybe go through.
Great. Megan, what I've included here are some of the more common questions that folks have when it comes to this new area of treating folks with gastric bypass and binge eating disorder in an eating disorder treatment center. And because we're seeing more and more of these folks come into treatment, we are all learning together, and we all are seemingly coming up with some of the similar questions. So I've grouped some of them together, and after we answer these, there's some lots of questions that folks have written in, so we'll get through as many of those as possible. And if you want to go through these, or
that'd be great. Yeah. So the first is weight loss a main focus of binge eating treatment? And when I say binge eating, I'm kind of saying binge eating / post-bariatric, just to go a little bit with the two of those. But I think this is an important question because there's a big debate on what you're supposed to focus on first. Going back to that first slide with the overview, is this a medical condition or is this a psychiatric condition? And there's a big debate on whether or not when someone starts to seek treatment for binge eating disorder, whether you focus immediately on getting some weight loss going, or if you're focusing on the behaviors and the psychiatric aspects of that with the therapy, the underlying issues. And what I've really seen to be the most beneficial is to do both at the same time. Just like with an anorexic that comes in and isn't cognitively able to function because of their low body weight, we're getting them to restore immediately. With the binge eater, they're all there. They're able to start that therapeutic work right at the beginning because while they're not in a healthy body, they're also not in a completely malnourished body. So what we've really seen is if we start focusing on getting them to reduce their binge behavior, getting them on a meal plan that's got more structure, that supports weight loss, and then eventually starting to encourage a little bit of physical activity, that weight loss and the encouragement that they feel and see in their bodies also helps them to focus on some of those psychiatric underlying issues and really keeps them motivated for this process. Now, it's a whole different story when you have someone that's struggling to be honest, is non-compliant with the meal plan, is expecting significant results in a very short period of time, sort of unrealistically. If you can get someone to really focus on those two things at once, they really buy into that treatment process a lot sooner. The second question we have is how do you designate eating disorder behaviors from the side effects of bariatric procedures, which I went into a little bit earlier, but one of the things that's really important in doing this is to find out what their motivation is behind the different behaviors. So for instance, if they know that they had eaten something that they probably shouldn't have, for instance, a dessert, are desserts more commonly things that they tend to vomit up? And I tend to actually differentiate the words vomit and purge when it comes to working with somebody who's post-bariatric, because it is very important that you validate the fact that they can have moments where it's an involuntary vomit and they had no say, they had no ability to control what it is their body was reacting to. But there can be instances where a person has started to kind of see that this behavior will go ahead and allow them to have additional weight loss and therefore turn into purge-like behaviors. So in validating that there can be moments of involuntary vomiting and moments where they're actually purging, it really helps them to get that validation that they need, and they can start to see that there are differences depending on the motivation that was behind the reason that they did this. It's also important as a dietitian that you're looking at specific foods. Everyone reacts differently after these bariatric procedures to different foods. Some people can eat just about anything as long as they're doing it in a small enough portion and they're they're chewing their food effectively and they're eating slowly, versus other people who find that there's lots of different foods that tend to kind of result in stomach discomfort, gas, dumping syndrome, or even the involuntary vomiting. So having a pretty specific list of foods that they keep track of and they see the reactions to and that you work with them on really helps to differentiate some of those things. The other thing is the restrictive aspects that can come along with mimicking the eating disorder behavior, and that's about getting them on a really, really strict meal plan. Again, working with them on what foods work for them, making sure that they're getting enough of the specific nutrients that they need in order to have a healthy, functioning body, but to really make sure that each day they have a consistent pattern, just a pattern of eating, just like you would do with an anorexic or a bulimic. And it takes a little bit of guesswork and a little bit of working back and forth in order to find that, but that really does eliminate their ability to say, oh, I never got hungry until dinner time. Well, that's not okay. You need these nutrients no matter if you're hungry or if you're not hungry. So you can really set some very specific goals and guidelines around those things to make sure that you're designating eating disorder from physical discomfort. The next question is, what are some of the differences in treating binge eating disorder? And I guess that would be in comparison to the anorexic or the bulimic population. I had the ability in our intensive outpatient facility, we at one point had 6 to 8 binge eaters. Some were just binge eaters, some were post-bariatric binge eaters as well. And I was able to have a few instances where I separated them from the rest of the population and just did some general work with them in group. And I really did find that they have a lot of issue at the beginning trusting the community, and feeling like they can be honest, again, going back to that really heightened sense of shame around their behaviors, feeling like they're constantly being judged. And again, I know that these are common with anorexics and bulimics as well, but it really does hinder and limit their ability to talk at all. They tend to just withdraw into themselves. They tend to still be observing others and relating, but it really is a struggle. And there's an interesting dialogue that happens that's a little bit different when you just have those that are overweight, those that are binge eaters, together. They want to have conversations where they're able to freely talk about their weight and their discomfort in their body, using words like fat or obese. And those are words that are difficult to use in a population where you have the anorexics and the bulimics present, because those anorexics and bulimics tend to want to relate to feeling the same way. And what it does is kind of devalidate those binge eaters who are actually overweight or obese, and they tend to, again, continue to withdraw. The other thing that you can do around food is you can really challenge them with certain things like practicing leaving food on their plate. With an anorexic or a bulimic, you want them to finish their plate, eat 100%, but with a binge eater, it's kind of a good challenge to ask them to leave food on their plate, to stop when they're full, to practice those different things. That can be a little bit of a comparison factor when you have the communities together. I kind of segued into that final question there, the benefits of having binge eating disorder and being able to separate the patients in a treatment setting. But I do want to say that there's a positive along with that, in that when you have a binge eating population with the anorexics and the bulimics, and they can really connect in some way and start to see each other as being people and humans, and they can relate in their eating disorders and not necessarily just in their appearances, it's a really powerful thing. And when you find that they're hanging out together outside of group and they're really supporting each other and they're encouraging each other, it really does allow all of the different types of eating disorders to get out of their preconceived notions of what everyone should look like and really start to see each other as people, which is a powerful message once they finally get there. Great, thank you. And we do have a couple minutes, Megan, with a lot of questions waiting on the line, and so I'll just go through as many as we can. Megan, can you say something about how you assess exercise and how you handle that? Yeah, that's terrific. We've really started to grow in how we're dealing with exercise. Obviously, we don't touch the exercise piece until there's been complete medical clearance from a physician, because it's just really too risky. Again, the second thing that we really assess is their ability to ambulate or move about. So what we've really started to do is incorporate swimming as a big part of the exercise piece. Whether it's at the outpatient level of care, we encourage them to go to a local community center or the YMCA, or even a gym, which is not as common to get some pool time in, because that's going to make sure that they don't fall and hurt themselves, that they can get some relief from the joint pain that they're having, and they can get some cardiovascular physical movement going that's not quite as difficult as actually going on walks. The challenge with the swimming is getting them in a swimsuit and around other people. So once you can really work through that body image piece with them and encourage them to do this because it's so important for them, then they really do enjoy the swimming. And then we'll start to incorporate things like chair yoga and walks a few times a day and all of that. But we do it very slowly, very slowly.
That makes sense. And another question, the next question is, can you give an example of a starting meal plan for somebody like this and then how that might evolve over time?
Yeah, definitely. It really depends on the compliance level of a patient. So for someone who's coming in with post-bariatric procedure, we're going to find out what kind of procedure they had, and we're going to definitely find out what they've been doing. If we can contact the doctor depending on when they've had the procedure, sometimes they had it 7, 8, 10 years ago. So at this point, it's kind of irrelevant because they've just, done whatever they wanted to do anyway. We'll try to work with the meal plan that they're doing. If they're post-bariatric, we have them on 6 small meals a day, and the idea is that they're never starving and that they're never hungry and they don't feel deprived. So they know when the next meal is going to be coming and that they're getting as much of those essential nutrients as possible, which is so important with the post-bariatrics. It is a higher protein diet. It is a lower carbohydrate, lower fruit. Oftentimes nuts and seeds are avoided when it comes to the bariatric surgeries. And then vegetables have to be cooked, and they're done minimally because there's often a lot of supplements that are taken in order to get a lot of those different vitamins and minerals into the body. Now, for a binge eater specifically, if they come in ready and willing for treatment, then we'll go ahead and start them on the meal plan we think they should be on, which is slightly restrictive in calories. Obviously, we don't want them to be hungry, but it's a little bit lower in calories. And if they're really struggling, we'll bump them up a little bit so that they don't have that fear of being restricted. So oftentimes we'll start them a little bit lower than we think they need to be, and we'll see how they do with that because they've never really checked in with their hunger fullness cues. If someone's really struggling, then we'll give them more food than we think they need. And the whole time we're kind of telling them, this is more than your body needs. This is more than you need, what's going on emotionally, what's going on with regards to your urges, and we'll try to work with them. So oftentimes we'll start them a little bit lower and then tend to bump them up to a place where they need to be. But if they're really struggling, then we'll give them more food than we think they need in order to help them really see how their eating disorder has played into this.
And the questions are just flooding in. We only have time, I think, for one more. And can you say something about the typical weight swings that you have seen in this population? Is it similar to those with eating disorders, more or less?
It can really vary. If someone's post-bariatric, they can obviously drop weight very, very, very quickly. We don't often see someone who's post-bariatric within a year of a procedure. We're generally seeing these people 3, 4, 5, 6, 7, 8, 9, 10 years after their surgery, so their weight loss is usually pretty set at that point, and they're maybe gaining weight again. But when it comes to the binge eating disorder, we have seen people where they are gaining weight every single week that they come in, specifically at the outpatient level of care, the intensive outpatient level of care. We've seen people gain upwards of 30 pounds in a year. But then the second they stop those binge eating behaviors, that weight really does start to trickle off pretty quickly. So there really is a significant flux that can happen depending on the binging behaviors. However, I would say it's less than the swings that we see with somebody who's a bulimic. So it's really interesting.
Yeah, boy, that sounds like quite a process. And just very quickly, we have a second or two. If you could touch on what the long-term treatment looks like for one of these folks.
For somebody who's a post-bariatric, it's establishing that meal plan and making sure that they follow it consistently to avoid any complications of their surgery and to make sure that they're a healthy individual with all the vitamins and minerals that they need. Their weight stabilization is obviously a huge part of that because then it's going to tend to less trigger them to want to have different behaviors, and then there's the therapeutic aspects that go into it. For someone who's a binge eater, it's getting them to understand that they have the power to take care of themselves, and that not only only includes taking care of their body, but taking care of themselves emotionally without the food. So it really is about creating a new lifestyle for them.
And that sounds like a lengthy process and a worthy one at that. And we are at the end of our time, Megan. That was a fantastic overview of this complicated topic and what you've seen over the last few years. And I want to thank you for coming in and doing this presentation with us. And for anybody who has questions or would like to have a copy of the slides, go ahead and contact me at my email. You see it on the last slide here, libbyneal@rosewoodranch.com. And this will be posted at the rosewoodinstitute.org website about 24 hours after you hear it here. And I will see you at our next clinical webinar lecture series. And thank you very much for